But sir, just so you know we've had 37 summits in the district.
But I think that those 87 summits didn't happen with a bill on the table. And none of them dedicated purely to health reform.
But that's why I did the very first one in my district.
Yeah,
but then when I was invited out here,
I don't want to debate that with you right now, but I would like to ask you a question. You talk about the three primary reasons: preventive care, the public option, and then minimum benefit levels. And I can agree with you on one. Minimum benefit levels is important. On the other two, I think you're contradicted by a long literature on preventive care. The Congressional Budget Office and the academic literature demonstrates fairly conclusively that preventive care doesn't save money. And the reasons are complex, but you end up testing more people than you end up saving. And so a plan that looks to expand coverage through Medicaid and expand utilization through preventive care with no cost sharing drives utilization like crazy. And this is the experience in states that have tried this. And then the public option, the issue is cost sharing. We've heard today about how costs are transferred from a public option to people with private insurance. And we are within a mile of two businesses that employ 10,000 health insurance workers. The Congressional Budget Office has not estimated the implications of cost sharing. Could be devastating for the health insurance industry. There could be no reasonable competitive choice versus the public option. And I'm just interested in how you respond to that.
Let me take the first one. I've sat down with the Congressional Budget Office on this, trying to ascertain the exact figure of how much you save by preventive care. What their consternation is, and they've done some and admitted that some of it is what they're trying to finish modeling is this. Well, if we're doing this preventive care and people are living more healthy, they'll live longer. So doesn't that mean eventually we might pay more because they're living longer? Instead of passing away at 80, they'll be living to 84. Yes, that's their issue. So the issue, actually this is an important issue. They have recently, when we sat down and went through this with them, and because statistically I wanted to come up with a firm number, because I believe numbers are, well, frankly, I think you should have a fact on the table. Now, they have come up and ascertained that you do save more money, but they're unable to say if it's overtaken eventually because people are living longer or not. So it's a statistical modeling that's never been done. Number two is public health care plan. I want to make sure I understand how this question went, so I'm answering it correctly.
The issue on cost sharing, if you think about healthcare in terms of units, a unit of healthcare costs $1. Medicare and Medicaid pay only about 80 cents. That 20% difference per unit is picked up as an implicit tax by people with private insurance. And what happens is that more people migrate to a public option.
Yes, I understand.
The premiums for people with private insurance go up.
Yes.
And therefore,
yes.
you have an incentive as a private insurer to move people to the public option. And this is the glide path that people are criticizing towards a single-payer system.
Excellent question. See, because the way the public health care plan option originally it was when you set this up, originally they were going to charge reimburse rates of Medicare plus 5%. We've changed that in the bill. The bill that's online doesn't show it. This one here, but we have changed it since then. When it went through the Energy and Commerce Committee, and they haven't put this online, why this gentleman who wants this pledge is very well taken, is what we've now done is mandated, see, at first it's going to be Medicare plus 5% for the first 3 or 4 years till it got up on its feet. Nope, we changed it. From day one, they must negotiate like any other private health care plan with a provider for the market price. No, that's how the law is right now, if it continues all the way through the House.
But the burden placed on the public option is quite different than the burden placed on a private health insurer in Philadelphia. If you're Independence Blue Cross, if you're Aetna, if you're United Healthcare, you have to go out doctor by doctor by doctor by doctor and come up with an arrangement or you can think of it hospital by hospital, to come up with an arrangement that works. What the public option does is it leverages the power of the federal government via Medicare and Medicaid in order to fix it. It does. It absolutely does. You need to go back and look at it, because that's exactly what it does. It uses Medicare and Medicaid reimbursement, and it uses expanded Medicaid eligibility. So it's an expansion of two public health plans that are financially unstable, virtually insolvent at this point. These demonstrations have been tried in other states. They don't work. It nearly put the state of Tennessee out of business twice. I was involved. I lived there and studied the program. I think that there are economic underpinnings to the way that this plan and this philosophical legislation, I know it's not final, the way that this works that are incredibly damaging to the delivery of healthcare in this region, the financing of healthcare in this region, and the employment of people, particularly in your district, which is overrepresented by healthcare workers and health insurance workers relative to this district. So
He's right.
These are very serious issues.
22% of my district is actually in health services on that. But I'm happy to sit down with you again. Happy to sit down with you. The way this is presently constructed is it is only subsidized by the co-pays or the premiums of those who join, not the government. And number two is they have to barter just like anybody else in the marketplace in order to get whatever price they'll pay a provider. But I'm happy to go through. He's wrong. Well, I don't mean this. Excuse me, let me just say. He's wrong unless, but yeah, I mean, that's not how the bill is. It's not correct.
I recognize we'll have to move on. I recognize we'll have to move on, but I think if you read the congressional, and I encourage people, go out to the Congressional Budget Office, read their memo from July 26th, where they talk about the $1 trillion in outlays that have, you've described it as a loan.
Yes.
But that's subsidized by taxpayer dollars.
Yeah. What I said is, for 10 years amortized, I made it very clear the government gives it a loan that has to be paid back, and over 10 years amortized, it has to pay it back, and it's just so you can start it up. Like any outfit, you need a kickstart to get it going. So that's all it does with government money. After that, there's no federal government involved. No federal money involved. And to your point, yes, that's not correct the way it is set up.